So good morning, good afternoon, ladies and gentlemen. Thanks to join today's seminar. So I'm Nina, the CEO of Overseas Medical Mission Center of Changhua Christian Hospital. I'm also today's moderator. And first of all, I would like to thank our distinguished guests, participants from Papua New Guinea and Taiwan, and our two speakers, Dr. Su and Dr. Sodeng. So before we start our seminar, I would like to invite our distinguished guest to give the remarks. First, I want to invite my good friend, the representative of Papua New Guinea Trade Office in Taiwan, Mr. Tommy, to give a remarks. Tommy, please.
Good morning, everybody. Firstly, let me thank Dr. Nina, the Changhua Christian Hospital, the Ministry of Health and Welfare, R.O.C. Taiwan, and Port Moresby General Hospital for organizing this online seminar on discussing diabetes, a disease which in 2019, it ranked 5th among the top 10 causes of death, and it's 5th in both Taiwan and Papua New Guinea. So through this online seminar and presentations by Dr. Sodeng and Dr. Su, we can share the experiences and strategies of diabetes care, both in Taiwan and Papua New Guinea. Hopefully it will help us and enlighten us so we can collaborate more or for further collaboration or exchanges between Taiwan and Papua New Guinea, more specifically between Port Moresby General Hospital and the Changhua Christian Hospital, not only in the management of TB, but also in other diseases like COVID. So hopefully we can have more online seminars like this. So thank you.
Thank you very much. Thank you, Tommy. So the next, I want to invite the Councillor Liao on behalf of the Ministry of Health and Welfare to say a few words. Councillor Liao, Jijian, please.
Tommy Kunji, Ambassador Oliver Liao, Dr. Randy Mock, Dr. Nina Kao, distinguished guests from Papua New Guinea and Taiwan, ladies and gentlemen, good morning. It's my pleasure to attend the Taiwan and the PNG Online Seminar on diabetes care and welcome all of you to this event. I would also like to take this opportunity to wish you and your loved ones good health in this pandemic era. The PNG is Taiwan's important ally in South Pacific region. Over a decade, our ministry has worked with Ministry of Foreign Affairs to conduct the PNG medical program, which the Changhua Christian Hospital has been working on the projects including mobile medical services, medical staff training, equipment donation, international patient referrals, and so on. During the pandemic, Changhua Christian Hospital transformed the on-site clinical training to online training courses to continue sharing the latest knowledge to build the capacity of the cooperative hospitals in PNG. On behalf of Ministry of Health and Welfare, I would like to take this opportunity to thank Changhua Christian Hospital for its continued support and the contribution to enhance the relationship between Taiwan and the PNG. In conclusion, I wish this seminar a great success and hope all of you enjoy it. Thank you very much.
Thank you, Councillor Liao. The next, I want to invite the Representative Liao from Taipei Economic and Cultural Office in Papua New Guinea give remarks. Ambassador Liao, please.
Thank you, Nina. Good day to everyone. My name is Oliver Liao, the representative of the Taipei Economic and Cultural Office in PNG, Taiwan's de facto embassy here in Port Moresby. It is indeed a great honor and pleasure for me to witness the opening of this online seminar today. In spite of the absence of diplomatic relations between PNG and Taiwan, our two nations have long enjoyed friendly relations with each other. Bilateral exchanges continue to flourish, especially in the fields of agriculture, medical services, and education. And in the past few years, Changhua Christian Hospital had been supporting their counterparts here in PNG by sending mobile medical teams or providing medical supplies to PNG. However, due to the outbreak of the COVID-19 pandemic, international travel has become very difficult. Therefore, they came up with this idea of holding the online seminar today so that they can continue to engage with their PNG counterparts and continue to provide support in an alternative way. We just heard from Representative Thomas Kunj and also from the presentation from Dr. Sodeng that diabetic continue to be a challenge in PNG, and I guess it's also the same situation in Taiwan. We all know that diabetic is a chronic disease, very common in the world. Caring diabetic patients has always been a challenge, and the current COVID-19 pandemic makes it even more difficult. Therefore, I think it's a wonderful arrangement to bring experts from our two sides together today so that they can share their observation and their experience caring for the diabetic patients. It won't be wise for me to take up too much time speaking at the seminar, so I think it's been going pretty smoothly. Finally, I'd like to close by acknowledging Changhua Christian Hospital for their efforts in organizing today's online seminar, and I wish all the participants of this online seminar a fruitful and successful discussion. Thank you.
Thank you, Representative Liao. So maybe we can start our today's presentation. It's okay for our two speakers? Okay. As you know, the diabetes is a common chronic disease in Taiwan, Papua New Guinea. The prevalence rate has been rising, especially in low and middle income countries. And from 2020, the COVID-19 pandemic brought a huge impact on our daily life, especially for the medical staff and patients. Until now, we are still fighting with the pandemic. So today we invite doctors from Changhua Christian Hospital, Taiwan, and Port Moresby General Hospital to discuss the challenges and the strategies about the diabetes care before and after COVID-19 pandemic. The first speaker, we want to invite Dr. Sodeng, and he is the medical officer and leader of the internal medicine team at Port Moresby General Hospital. And Dr. Sodeng, he will going to talk about the diabetes, the Port Moresby General Hospital experience. Dr. Sodeng, the floor is yours.
Okay, thank you. Just a few remarks. Our internet is a bit playing up, so there might be instances where we might go off and then come on again. Okay, thank you. And greetings to all of you from Port Moresby, Papua New Guinea. Okay, I'm just going to talk briefly on the Port Moresby General Hospital situation, and more or less it's reflective of the rest of Papua New Guinea as well. Okay, next slide. Okay, thank you. So this is just a diagram of the Port Moresby General Hospital, the front part of the hospital. Okay, next slide. Okay, so like as we all know, lifestyle-related diseases are on the rise in PNG, and that's added burden to all the other. So we are seeing a lot of increase in hypertension, diabetes, cancer, stroke, and coronary artery disease, chronic kidney disease, etc. So The ever-present burden of communicable diseases remains and is also on the rise, and that's including the other infectious diseases. And that's putting a burden on the health system of Papua New Guinea. The association between type 2 diabetes and TB is now becoming common as well. We are seeing a lot of TB diagnosed in diabetic patients and vice versa. And now that we have the COVID-19 pandemic, it adds more burden to the already burdened PNG health system, which is already struggling. Next slide, Taylor. Okay, so from this table, as you can see, in the last 4 years, diabetes has been ranked as one of the leading cause of admissions for the years 2017 to 2020, and even 2021, it's still ranked in the top 5 cause of admission to the Port Moresby General Hospital. Next slide. And the leading causes of death at the Port Moresby General Hospital medical wards from 2007 to 2019, again diabetes in the top 10 cause of deaths, especially with complications, diabetes related complications. So it's still a big problem in our setting. Next slide. Especially in our setting, occasionally we have stockouts of DSL monitoring glucometers, non-availability of some other tests, including the monitoring tests, HbA1c, urine ACR, and all this. And also with the limited range of medications we have, I think the most commonest oral glycemic agents we have is glibenclamide. And also insulin, we do not have the luxury of all the other range of insulin. We only have limited range of insulin injections. And chronic kidney disease is a big challenge, rising challenge, especially with diabetes. And it's a challenging diabetes and chronic kidney disease. Next slide, Taylor. Okay, so as already mentioned, the range of oral glycemic agents we have on our end is limited to only glibenclamide and metformin. There are other options, but these are sold at the private pharmacies, and it costs a lot of money, especially for an ordinary Papua New Guinean citizen to go and purchase. And in terms of injections, we only have the short-acting, which is the epcrepid, the intermediate-acting, which is the isofen, and the mixture of the above two. We don't have the ultra-short-acting and the long-acting ones. So we also have a limited range of insulin injections that we can offer to our patients. And that's reflected of all the other hospitals in Papua New Guinea as well. Next slide, Taylor. Okay, so the commonest complications we see with our diabetic patients, especially in the medical wards, it's chronic kidney disease, and with its associated effects. Eye changes, retinopathy, maculopathy, and then especially in the surgical wards, you have diabetic ulcers, foot ulcers due to diabetes, neuropathy, and the others. But the main one, challenging one that we see is chronic kidney disease associated with diabetes. Next slide. Okay, continue, next slide. Just initially, because of the fear of the pandemic, most of the patients, especially those with underlying medical conditions, were not properly screened. So some of the cases, especially diabetes, most of diabetes are not the COVID itself. As you can see from the diagram, and I'd like to thank Dr. Seki for the diagram. This is the monthly admissions and deaths from COVID-19 from 2020 to 2021. Next slide. By the summary of the admissions, the case fatality rate, the admissions. So as you can see, there was a surge early this year, and then it sort of died out. And at the moment, I think we only have a few cases in the ward now. And also that was associated with the deaths. Initially, early part of the year, there was a number of deaths, but this has gone down. And then the case fatality rate, also early part of the year, but it has also subsided. And this is from the COVID statistics. Next slide. Okay, the PMGH group COVID-related deaths. So I'm speaking for the Port Moresby General Hospital. 27% of all COVID-19 admissions at coexisting type 2 diabetes. And out of that, total COVID-19 deaths were 68. From that 68, 20 of these patients had type 2 diabetes, so a total of 41%. So diabetes is one of the main underlying comorbidity with those patients coming in with COVID infection. Next slide. The challenges faced during the lockdown. During the pandemic period or the lockdown, all the consultations clinics were closed, and prescriptions were only given to patients without even assessing the patients. And even the patients, some of them were afraid of coming to the hospital, so most of them were lost to follow-up. They were not on treatment. The hospital pharmacy also scaled down its services, and most patients, including diabetics, were not able to get adequate supplies of the medications. And for patients to be admitted to the intensive care unit or the high dependency unit, there was strict criteria for these admissions, and that included COVID-19 to be ruled out before patients were admitted. And some of the patients, because of the delay, some of the patients deteriorated whilst awaiting admission to, awaiting the results before admission to these ICU and high dependency units. I just came back from a 1-week break, and I went over to New Island province, and I did a diabetic clinic, and from that experience, the medications ran out, the oral glycemic agents ran out, and most of the hospital, the staff, they were concentrating on COVID and all this stuff, and they forgot about diabetic patients. So the diabetic medications ran out, so some of the patients did not get the medications. So still a big problem in terms of the existing medical conditions and COVID-19. So COVID-19, when it came, it sort of affected the whole function of the hospital, not only diabetes, but almost all the other sections of the hospital. Next slide. Example of a case, COVID-19 testing and clearance issues. Strict orders to test for COVID-19 before admission to the acute wards, especially to ICU and Ward 7, which is the high dependency unit. Has been counter patient care and has been at the cost of losing lives. Example included a case of acute myocardial infarction that died in the ward, and a type 2 diabetes patient that died in ED from manageable complications whilst awaiting transplant. So COVID did affect the general performance of the hospital, and especially included diabetes as well. Next slide. So the number of young people increased, and that was post the COVID lockdown. At one stage, the on-call team admitted about 5 cases of possible type 1 diabetes in patients less than 35 years of age. We're not really sure if this is related to COVID as a possible underlying cause of that. Next slide. So finally, after the lockdown, there was a surge in the number of patients, including diabetes, fronting up at the clinics for review. And again, all that was the same picture for all the other patients, TB and the other clinics. On month of medications, and are now coming back with poorly controlled blood sugar levels and even complications. And the struggle with managing diabetes continues. even after the lockdown. Next slide. That's the last slide. Thank you.
Thank you. Thank you, Dr. Sodeng, to share the situation before and after of COVID-19 in Papua New Guinea. And we're going to continue our presentation. So the speaker is Dr. Su, and he is attending physician of Division of Endocrinology and Metabolism of Changhua Christian Hospital. And Dr. Su will present the framework for diabetes monitoring and surveillance in Taiwan and the strategy under COVID-19 pandemic. Okay, so Dr. Su, the floor is yours, please.
It's my honor to introduce the short talk. Today, my topic is the framework for diabetes monitoring and surveillance in Taiwan and the strategy under the COVID-19 pandemic. This is my outline. First, I will introduce the COVID and the diabetes relationship. And the secondary, I will talk about the guidance about the diabetic care during the pandemic, especially in the Taiwan. The third part, I will talk about the CCH cash sharing in this period. Then we'll give the summary. From the last data together from the Johns Hopkins the data, COVID-19 has been diagnosed about 200 million people get the COVID, and the death rate will be the death people about 4 million. The the whole world ranking, Papua New Guinea about 138, and the Taiwan is just body. It's 139. So we can find that this problem happened in your country and my country. 90% of the COVID-19 patient will have the comorbidity. The first one is the hypertension near 15, and obesity and the chronic lung disease. The fourth is the diabetes near the 30%, and the cardiovascular disease also near the 30%. So we can, from this study, from this statistical data, we can say the diabetes patient and is the equal mobility with the other disease. So not so many diabetes patients get the COVID-19 than other disease. Why we are so topical in the diabetes? Because diabetes patients get more ICU admission and more deaths. Why is this the mechanism? We can see when the COVID-19 binding the ACE protein through the spike protein, then into the cell and the tissue. Also, he will be get the viral replication. Then the virus, the amount will be increased. Then they will induce the cytokine storm, and they induce the our lymphocyte exhausting. Then the immune response will get the sick. If the patient have the diabetes, he get the hyperglycemia. When hyperglycemia happen, they will regulate the innate and the human immune system. Then the immune defense mechanism is the low, and also chronic low greater inflammation will give the exacerbated effect. So diabetic patient will get the more multiple organ inflammatory response. So from the one study, they showed collect about 10 countries diabetic patient. They find what kind of the diabetic patient will get the more severe death and the severity and the death. The first one is the male sex. So the man will get more death. The secondary is the old age, if the age over 65. The third is they have the high blood glucose when he admission. Now, then we'll give some evidence to show you. And the fourth will use the chronic insulin use. This is means the poor glycemic control before this episode. Others is with the other comorbidity. I think that's the rationale because there is a more sickness. So from this data we can find we can correct the factor that is the blood glucose is the most needed to target. 不往下走了。No, next. Okay. From this data, we can find the survival rate. The non-diabetic patient is good than the diabetic patient. If the diabetic patient is well controlled and the poor control, we can find the poor control with lower survival rate. When the patient get the COVID-19 virus disease, we will give the therapy. The first one is the oxygen. The second is the steroid, and the third is the antivirus or anti-cytokine reagent, such as the chloroquine and the lopinavir and the interleukin-6 antagonist, receptor antagonist, and the interferon, and the most famous that's the remestemcel. Because after we use this one, we can find lopinavir. They will increase the sugar. It can increase sugar, inhibit the glucose in uptake, and make the hyperglycemia. Also, we know that when we use the steroid, the sugar will also high. So when the patient get the anti-coronavirus therapy, they will be deteriorate the glucose level. So the DM have the poor immune, and he was in the pro-inflammational status. He will many cytokine reaction and higher oxygen stress. When they get the COVID-19, they also will COVID-19 also induce the pancreatic injury and the insulin resistant, and also induce the cytokine storm. And when you use the steroid, there will be interaction with the DM and the COVID-19. This will be become a vicious cycle and make the patient more severe and then get the death. So in the clinical physician, we just want to stop this condition. So then many countries, including Taiwan, get the guidance to help a physician how to treat this status. When we see the patient, this is also the data from the ADA. We can find that diabetes patient is the survival probability is also still poor than the non-diabetes. If the patient without diabetes, we can see the left side. Red one, like this one, is the already known. Here's the DN, and the green one and the purple one is non-diabetes history. But when the glucose is good, so they were sent. But the non-diabetes, he also have the hyperglycemia. The mortality is similar like the diabetes. So we can find the initial glucose concentration is very important. Also, if we divide the to 5 parts of the glucose level, the better one is the higher one. So we can find that this is the situation. And this is a patient in the non-ICU and admitted to ICU. We can also find the same condition. If the sugar is higher, the survival is lower. ICU and the non-ICU is also the same. So normalization glucose is the key point to make the diabetic patient become survivor. So we will use the many kind of the drug to survival to lower the glucose. Metformin, I think that is also apply in the PNG, but in Taiwan we also have other drugs like the DPP-4 inhibitor and the GLP-1 agonist and the thionyl and the sulfonylurea, SGLT2 and the insulin. So we are so lucky we have many weapons to lowering the glucose. But some status we should know how to use this kind of the drugs. In the Nature Review and the Endocrinologist this year, they give the clinical management guideline. They show that when there is the upper layer is the recommended use the agent. This one is the health people. The left one is the health. The second column is the mild disease, and the right two is the hospital, and this is in the ICU. So you just mentioned when in the ICU, when in the hospital, insulin is the first, and the DPP-4, if you can eat medicine, DPP-4 can be choice. Metformin and the GLP-1 can be used. And if they some kind of the drug will be caution, like the sulfonylurea and the SGLT2, because SGLT2 will induce the euglycemic DKA, so it make the condition more severe and severe. So we can, so from this summary, we can use the such kind of the drug to help our patient. Taiwan also have the this the guideline which was made and the Jew and the Jew they give us the recommendation is the depending on the sugar level. If the sugar is less than 200 milligram per deciliter, you can use the DPP-4, metformin, and the basal insulin. If there is a moderate high, 200 to 300 milligram, you can use the DPP-4 and the basal insulin. And if over the 300, you just use the insulin. Okay. Now I will move to the Changhua Christian Hospital case. During the past 2 months, we have the 94 patient admission due to the COVID-19. We have the 5 cases expired. We do not have so many diabetes patients. Only 18 have the diabetes patient, and only 5 admitted to the ICU. So our data is not similar like the other 2 reported. First one, I will introduce the 62 female. The symptom is the poor appetite and the neck stiffness just for 2 days. She come to the our hospital because it's a fatigue, malaria, and conscious dosing. Then she get the screen and find that the COVID is the positive. He also have the past history is the hypertension and type 2 DN for 5 years. Because this patient is not a regular follow-up in our hospital, so we did not know the previous medicine from her. The physical examination is the only bilateral cross-breathing sound. when she admission, we get the chest X-ray. We can find there's the ground gross pneumonia patch over the left side and the right side, the lower layer, and the upper layer also a limit. His hemoglobin is the 80 point, and the glucose is the one near 200, near 200. But because we do not know his previous medicine, so we just give the reprogram 9. The COVID-related treatment, we give the dexamethasone 5 milligram IV for 2 weeks, and we also give the preventing antibiotic, 2 kind of prevention antibiotic. The blood culture is always negative, so without secondary infection. You can see the glucose is always below the 200 milligram per deciliter. So its control is very good. So then the patient recover. We just follow this recommendation when the patient is can walk, so we can use the metformin and use the to control his when he admission, we also use the metformin to get a good control. Yeah. And the secondary case is the 63 male. His symptom is the fever and the cough since 4 days. She has a watery diarrhea for 10 times, and she come to our hospital because the dyspnea and the desaturation of the oxygen for 1 day. So when he go to the our emergency room, he get the endotracheal tube intubation. She passed no other past history, so he is very healthy people during the past. The physical examination just only also see the cross breathing sound over the bilateral lung field. This is the initial X-ray when she get in the ER. We can find the pneumonia patch is very diffuse bilateral, and after treatment, the 30 days, the lung is more still, it's more clear, but still and some small patch. This case, we can see the initial in the ER, sugar is 118. It's not fit the criteria of the diabetes, no A1C data, because she have no diabetes history. But when we see the sugar pattern, you can find the sugar is very, is also sometimes higher than 300. And during the medicine for the COVID-19, we use the prednisolone and the preventive antibiotic twice, and also get the blood culture is the negative. Because the sugar is a fluctuation, we use the insulin plus the regular insulin plus the basal insulin. So every day we give the 4 times insulin injection. Then his A1C become a 7.2 milligram. So fit the diagnosis of the diabetes. When the disease is progressive, we use the regular insulin infusion treatment every hour. Then after come down, we just shift to the insulin daily injection. This case is the like the Dr. Songge say, they meet the patient after the COVID, they get the diabetes. Why is this mechanism? We can find the COVID-19 virus will binding to the beta cell surface in via ACE2 and via TMPR protein. They injure the beta cell. The direct invasion will induce the cytokine reaction, oxidative stress, and the ER stress. Then the beta cell function will decrease, like insulin synthesis decreased, and the ATP production is decreased, and the energy utilization is the decrease. So we'll get the new onset of diabetes. Maybe this type of diabetes may be transient or become like the type 1, still need a further observation to know the condition. Then we'll give the summary. If the patient have the pre-existing diabetes during the COVID-19, so the risk is the same with the others. But when diabetes patient get COVID-19, his risk is increased. They become a severe, the easy ICU admission, and the higher mortality. This is dependent by the sugar level. So we will normalize the sugar is very important. The other after COVID, long COVID-19 condition like the tiredness or briskness in the muscle pain, maybe still need further focusing. When during this time we use the antibiotic medicine, we just need to know the will be a new onset hyperglycemia in the infection the people. So if the patient without the diabetes usually be checked, also need to check his sugar. And all class of the anti-diabetic medicine is shoot in the mild case, but in the severe case, insulin is the only choice, like our guidance said. So from this episode, we're learning. First one, we were preventing the COVID-19, like the hand surgery, mask, and the social distance, and the vaccination is needed to do. And if unfortunately get the COVID-19, we needed to treatment. The treatment will also induce the metabolic issue. So we just need to follow the sugar, follow the condition, and also we needed to know patient with the other risk factor to make the modify the risk factor. The sugar control, we just can divide it to the glucose level. If the glucose level is good and the patient condition is good, then you can treat it as the major their OAD. If the severe, we just use insulin. The most important, we need to keep the sugar less than 200. It's very important. That's my talk. Thank you very much.
Thank you, Dr. Su. And so we are open for question. So if you have any question, you can raise your hand, and I will know anyone would like to ask a question. Before that, yeah, I think Dr. Damien, now he is in our hospital for training. I would like to invite Dr. Damien to feedback on today's online session. Damien, please.
Thank you, Nina. See attendance from Papua New Guinea. Thank you all. Firstly, I want to thank Dr. Sodeng and Dr. Su for the excellent presentations they have done on diabetes. And we all know that diabetes is a common problem affecting both PNG and Taiwan as well. I want to ask a few questions in regards to diabetes and COVID-19. I want to direct this question to Dr. Su, because we know that when there is diabetes and COVID-19, the mortality is quite fatal. And I want to ask you, in your experience, is there any medications that we can give as a prophylaxis for those patients with COVID-19 and diabetes to reduce the mortality? And secondly, in terms of those patients admitted to ICU, which type of insulin do we give? Do we give them long-acting or short-acting insulin treatment?
Okay. First, the question, I think is no medicine can prevent COVID-19 happen. Just we just use the wash hand, the mask, and the vaccination. So no other medicine can prevent the COVID-19. But a diabetic patient, if he maintain the good glycemic control, A1C is less than the 7 milligram per deciliter, he will get a good immune response. So maybe he can against the COVID. Or unfortunately, if he get the COVID, then the symptom will be mild and they will not be so severe. So this is the question. The first question. The second question, I just in ICU we just have the use the regular insulin infusion because he's continuing infusion, so the sugar will be controlled very well. If the condition becomes stable, we just use the regular insulin plus the basal insulin. So this is the two kind of the strategy which we just use to care our patient.
Thank you. Any other question? And I also saw many of my good friends from Nongka Hospital. So yeah, raise your hand to say hello with everyone. Any question, comments from my good friend from Nongka Hospital? Can you say a few words? Oh.
We were actually on with you guys.
Oh, that's good. That's good. That's good. Yes,
You can
yes,
hear
very
me?
good.
All
Yes.
right. All right.
Good.
Unfortunately, we were out of the net, so we are back again. And we are getting something downloaded, so we'll go through again later on.
Okay. Thank you very much for joining us. Yeah. So, yeah. Any other question on Dr. Sodeng? Do you have any comments or questions?
Yes, thank you. Just one question.
Yes, please.
With the resource limited setting like our setting, in terms of medications and all this, what is your best in diabetic patients? And I believe one of the issue is the fear. Since the pandemic, there was a lot of fear in dealing with diabetic patients, but that is sort of resolved, and especially the limited resources in terms of medications and all this. What is your best advice going forward? Thank you.
The cortisone, the corticosteroid is the best choice, especially the long-acting, like the dexamethasone is the first one. The secondary, we just use the prednisolone. So because the steroid used staging will be when patient give the O2 supply, but still not a good response, we can use the steroid. And the antivirus agent, we just mentioned should be earlier than the oxygen supplement, because when the COVID come into our body, they will get the immune response. Then the cytokine response will be happen. The cytokine storm becomes severe. That will give the dyspnea. So the steroid used endocrine used when the dyspnea and the O2 desaturation status will be stopped. Just our experience.
Okay. Okay, I think because time is almost up. So before I close today's seminar, once again, I would like to thank all of you to join us. And I also want to share with you our next online seminar will be on August 10th at the same time as today. We will invite Dr. Damia and doctors from Changhua Christian Hospital to share the kidney stone management. So most welcome all of you to join us again. So this is our next sessions on our seminar. You can scan the QR code to visit the website. You also can register. Welcome to register our online seminar on August 10th. We will invite Demia. He is the key speaker, and he will share us how he learned in Changhua Christian Hospital, because everyone know that he take the training at our hospital for 3 months. So I would like to invite him to share some of his what he learning in our hospital. So most welcome to join us next time. Thank you very much. Thank you again. So see you next time. Bye.